Actually, my talk is thyroid and autoimmune diseases and other association of thyroid with other autoimmune diseases, including rheumatic and non-rheumatic disorders. You just bear with me. I want to actively participate. It's a sort of interactive, so to make it more interesting, so that you should be actively participating. So it is a case, different cases. So the case one, 36-year-old farmer was recovered from the field in June with altered conscious level and high-grade fever. On arrival in the emergency, the patient was drowsy and he had a fever of 106 degree Fahrenheit, pulse was 146 per minute, blood pressure was 88 by 66 millimeter of mercury. His GCS was 20 by 15 and there were no focal neurological deficit or there are no signs of meningeal irritation. So I want the audience to participate. Okay, what differential diagnosis will you consider in this patient? Anyone? Yes, heat stroke, that is one. And actually that is the diagnosis, but traditionally we used to consider meningoencephalitis, septic encephalopathy and cerebral malaria in this patient. And especially if you have worked in the southern Punjab, so organophosphate poisoning can present similarly with high-grade fever and altered conscious level. Having said that, the pinpoint people usually give you the diagnosis. So the patient was rehydrated, cold sponging was done, and patient regained full consciousness but was unable to move any limb. The examination revealed flaccid paralysis of all limbs with power 1 by 5 with diminished reflexes and no sensory loss. So now what will be the diagnosis? This is the same patient who has regained the consciousness level, his fever has settled, the patient has got heat stroke, and the patient respond to cold sponging, but the patient has developed flaccid paralysis. Electrolyte imbalances. So what differential comes to your mind? So this is few differential which you will consider. For example, acute polymyositis, GPS, transosmolysis can also result in acute flaccid paralysis, periodic paralysis, and myasthenic gravis. So we rule out these one by one. Acute polymyositis, I think it is too acute for acute polymyositis even. And GBS areflexia is usually present, but again the patient develop the symptoms over some time. Transosmolysis is usually there is a sensory level, and periodic paralysis is one, and myasthenia gravis. Myasthenic crisis is another differential that should be considered in these patients, especially with patient of acute onset of flaccid paralysis. So the serum electrolytes reveal the potassium level of 2.6. So the diagnosis of hypokalemic periodic paralysis was considered, and the patient responded to potassium supplementation. The patient regained full power. However, the diagnosis is still incomplete. So what further test will you do in this patient? Thyroid function test. I think you must have seen the slides. Okay. Anyhow. So it's a rare association with the thyroid function test with a grave disease. So the thyroid function tests were done, and the patient reveals T3 was high, T4 was very high, with very TSH is low, and the final diagnosis is thyrotoxicosis due to hyperthyroidism, and the final diagnosis is hyperthyroid periodic paralysis associated with hyperthyroidism. It is not the familial type. Can you hear me? Yes, okay. So familial periodic paralysis, it's not familial, it's hyperthyroid, and the treatment for hyperthyroid periodic paralysis is the treatment of the hyperthyroidism. For familial, we usually use acetazolamide. So it's a rare association of hyperthyroidism seen in 1 in 100,000, 1 in 1 million persons, commonly seen in Asian males. Contrary to the the common gender frequency, as hyperthyroidism is more common in women, this is more common in males. This condition is more common in male, and usually it follows high carbohydrate intake. Usually it follows high carbohydrate intake and after exercise. And the attack may last for a few hours to a few days, and the symptoms resolve after the correction of hypokalemia. So the treatment is the standard treatment of hyperthyroidism, and acetazolamide is usually given till the standard treatment of hyperthyroidism is actually going to work. During that time, we can use acetazolamide. So this is the second case. A 36-year-old lady presented with generalized fatigue and shortness of breath on moderate exertion. On examination, she is obese, appeared pale with no lymphadenopathy. Abdominal examination is unremarkable. So these are the tests. So what abnormalities are present? So let's take it one by one. The hemoglobin is low, the TLC is low, the platelets low, patient has got pancytopenia, the MCV is very high, the patient has got macrocytosis, the MCH and RDW are probably okay, the creatinine is okay, B1 is okay, sodium is low, potassium is low normal, bilirubin is high, and it's basically indirect bilirubin, and ALT and ALP is okay. So the one thing that should be considered is hemolytic anemia, but very high MCV does not explain the hemolytic anemia. So one thing that should be considered in megaloblastic anemia, hemolytic, actually there is hemolysis. This hemolysis occurs during ineffective erythropoiesis during the cell formation in the bone marrow. So that can also result in this picture. And the megaloblastic anemia can also present with pancytopenia. So the macrocytosis is the clue. Pancytopenia, increased indirect bilirubin. But again, the diagnosis is incomplete. There is further clue to the diagnosis in the investigation, and that is low sodium. So the hypothyroidism is one cause of euvolemic hyponatremia. So in the presence of low sodium, the thyroid function test should also be done in this patient. And these are actually the actual patients. So the final diagnosis is megaloblastic anemia due to pernicious anemia or vitamin B12 deficiency due to lack of intrinsic factor associated with hypothyroidism. So my main topic is to highlight that if one autoimmune disease is present, there could be another autoimmune disease. We will see how much this is common. So again, the patient has got hypothyroidism, and the patient has also got pernicious anemia. I will skip this pernicious anemia slides. Now, the case 3. The 42-year-old housewife, known case of hypothyroidism, taking 6 tablets of levothyroxine, 50, sorry for the error, it's microgram rather than milligram per day, presented in the endocrine OPD with following TFTs. The free T4 is 0.2 and the TSH is 22. So that indicates inadequate replacement. So what are the likely causes? Because usually we don't go beyond 200 microgram of thyroxine. So if the patient is requiring 300 and the thyroid functions are not normalizing, so what is wrong with the patient? The possible causes are non-compliance, dietary or drug inhibition of absorption, or intestinal malabsorption. So the first thing is, if there is no inadequate response to any drug, you should check the compliance. And with thyroid, there is a very long list of drugs which can interfere with the thyroxine metabolism. So ideally speaking, when you give thyroxine, it should not be with food. And for example, 1 hour before taking any food, it should be given in the empty stomach. And the second, no other drug should be given with thyroxine. There should be at least a gap of 4 hours between thyroxine and any other drug. To, because you may not know whether the drug which are you using for any other purpose is interfering with the thyroxine. And the third cause is the patient may be suffering from malabsorption. So in this patient, we checked for anti-TTG that was positive. The patient has got celiac disease. So the celiac disease was causing the problem and resulting in increased dosages. So the patient was, so the final diagnosis is hypothyroidism with celiac disease, and the treatment is gluten-free diet. So coming to the topic, autoimmune thyroid diseases. These are the commonest organ-specific autoimmune diseases, affecting 2 to 5% of the population and about 10% of the women population. It affects more women than men, and the common diseases include grave disease and Hashimoto's thyroiditis, resulting in hyper and hypothyroidism respectively. So the classic the concept of autoimmunity present in this, there is presence of immunological tolerance, the presence of cells and immune cells response against antigens from the thyroid. And autoantibody generation. So these are prevalences of autoimmune diseases in adult population with autoimmune thyroid diseases. So you can look all the diseases association in, for example, type 1 diabetes, rheumatoid arthritis, pernicious anemia, SLE, Addison, celiac, vitiligo, multiple sclerosis, myasthenia gravis, and inflammatory bowel disease. The frequency of another autoimmune disorder is almost 10% in grave disease and about 15% in Hashimoto's thyroiditis. And rheumatoid arthritis is the most common among these. And the relative risk for other autoimmune disease in grave disease, Hashimoto's thyroiditis, is raised by the factor of 10 for pernicious anemia, SLE, Addison disease, celiac disease, and vitiligo. So these are some of the percentages. It seems boring, sometimes difficult to remember all these percentages. But the main thing is, if one autoimmune disease is present, there are chances that other autoimmune disease may also be present. So we technically label this as polyimmunity. So presence of autoimmune diathesis is when there is one autoimmune disease, it predisposes to another autoimmune disease. So this is autoimmunity predisposition. And autoimmune tautology is the autoimmune diseases share the same pathophysiology. So if there is one autoimmune disease present, so another autoimmune disease can also be present. If it is more than one, then it is known as polyimmunity. If there are 3 or more are present, then it is known as multiple autoimmune syndromes. So the clinical significance is the presence of multiple autoimmune syndromes is that it can alter the clinical presentation and alter the prognosis of the patient. So it may become better or may become worse. So this is polyimmunity. If one autoimmune disease is present, there is about 1 in 3 chance of another autoimmune disease to be present. Okay? It only matters which autoimmune disease. So I think there should be high index of suspicion to diagnose. I have highlighted these cases to give you some importance, some significance. If one autoimmune disease is present, then another one can also be present. So this should also be considered. So these are a few of the percentages of another disease with SLE, rheumatoid arthritis, multiple sclerosis, and Sjogren's syndrome. Familial autoimmunity. The presence of any autoimmune disease in the first degree relative is known as familial autoimmunity. The proband is the first index case. The first member of the family who has got a autoimmune disease, we technically call him as proband. So if proband has autoimmune thyroid disease, common autoimmune diseases in the First degree relatives are Addison disease, celiac disease, inflammatory bowel disease, myasthenia gravis, multiple sclerosis, pernicious anemia, rheumatoid arthritis, SLE, type 1 diabetes, vitiligo, and so SLE, discoid lupus. If autoimmune disease is present in the first degree relatives, the probands are predisposed to type 1 diabetes, SLE, rheumatoid arthritis, multiple sclerosis, systemic sclerosis, Sjogren's syndrome, inflammatory bowel disease, vitiligo, and there is the list goes on. So this is polyimmunity and autoimmune thyroid disease. We have been discussing if the autoimmune thyroid disease is present, then what is the chances of other autoimmune diseases to be present? Now this is if the patient has got rheumatoid arthritis, SLE or Sjogren's syndrome, what are the chances of these patients having thyroid disease? And you can see the numbers. So there are increased chances of autoimmune thyroid disease to be present in these such patients. Thanks. I think I will stop here. The key message is if one autoimmune disease is present, look for another. So and the chances are 1 in 3. Thank you.